Welcome to Inside the Studio, the official podcast of the Texas Heart Institute at Baylor College of Medicine. I'm Dr. Joseph Rogers, and together we'll explore the ever-evolving world of cardiovascular care. In each episode, we bring you conversations with the people shaping the future of heart and vascular health, cardiologists on the front lines of patient care, surgeons performing groundbreaking procedures, and scientists leading discoveries that will change medicine for generations. We'll also highlight perspectives from international leaders and community voices who share our commitment to preventing, diagnosing, and treating heart disease. Whether you're a physician, a researcher, a patient, or simply curious about the latest in heart health, this podcast is your inside look at innovation, education, and care at the highest level. So let's step inside the studio. Hi, I'm Dr. Joe Rogers, and I'm the director of the Texas Heart Institute at Baylor College of Medicine. And I'm joined in the studio today by Dr. Arvind Bhimaraj, who practices just next door at Houston Methodist Hospital and has just given grand rounds on the really interesting and provocative topic of myocardial recovery. And you've framed it up in a variety of different ways, and we'd like to get into some of those topics and explore them in greater detail. So Arvind, thanks so much for taking the time to join us today.
No, Dr. Rogers, thank you for having me here, and it's an honor to be here in such a legacy institute. And a lot of the recovery field was pushed here by the VAD work that I'm sure you're aware of. So it's a pleasure to be here, and I'm excited to, talk about my passion.
It might be fortunate for you that Dr. Frazier was not in the audience today. At least I didn't see him. But, he would take exception to the concept of recovery. He believes that remission is a much more appropriate term for some of the reasons that you described in your talk, and that is, although some people have improvement in ejection fraction, there's a group of them who will then go back into heart failure with a decline in their ejection fraction. So maybe we could just start there.
Yeah, and I think I've always heard Dr. Fraser talk about that remission concept, and I think I'm told he and Dan Burkhoff can debate it out who was a initiator of that concept. But it's absolutely right. I think the idea that the myocardium completely normalizes and then everything is okay is probably false. And then we see that in clinical practice. People's EF normalizes. They're completely normal. They go back to NYHA class 2 or 1. But we all know that we don't know when that EF drops. And no matter what you do, and at least in my experience, some of the gene mutation patients are always living on the edge because despite full GDMT, at some point they fall off the curve. And that was validated in our mouse model, showing that even though phenotypically the fibrosis is gone, the EF normalizes, the genotype has not normalized. And it's up to 19 weeks. At 7 to 9 weeks, the phenotype normalizes. Even at 19 weeks, there's almost 400 genes which have not normalized. So I think that remission concept, an injury is an injury. Once you get a scar, that genetic scar is something that's probably still there.
I think it fits probably with your experience, and I would guess that it replicates mine, and that is the people that you see whose ejection fractions go back to normal oftentimes aren't functionally normal. They still continue to have some amount of exercise intolerance. They still seem to have some amount of subtle heart failure symptomatology. And I've always thought it probably was because of their interstitium, right? And you created a really wonderful story. I was actually surprised to see, at least in your model, that you could reverse some of that interstitial remodeling, but I wonder if you would just expand on that a little bit.
Yeah, I think the myocytes end up being the workhorse, and I look at it as two entities. There are people who have myocyte ultrastructural genetic mutations. So in those individuals, I think the inefficiency starts with the myocyte not working well. But what we don't understand is the cell-cell interaction, and that triggers the interstitial area to act up and try to fibrotic it. And then in the other settings of hypertension or diabetes or MI, where the functional entire aspect gets affected, I think the starting point might not just be the myocytes. So this interstitial modulation, I feel, has just been ignored for all these years. And as I showed you in that single cell analysis, it's just fascinating to imagine that there's subtypes of these cells, which under the microscope look the same, but each one is having a different function, which just opens up our eyes, saying that there's so much that we haven't discovered. And then if you discover these things, maybe you can target it. I think that one subtype of endothelial cells having a healing property makes it very fascinating.
Yeah, I think that we undersell the complexities of the biology for sure. So if you look back historically at the models of heart failure, in the 50s, we sort of thought that there was an important aspect of kidney insufficiency, and we still obviously think that. And then as we began to do hemodynamic monitoring, we thought of it more as a hemodynamic disease. And then we discovered the neurohormones, and we used medicines to block neurohormones. And so we had the neurohormonal era of heart failure. And now I think you're taking us to this next really interesting era where we're getting down into the really interesting aspects of what's likely to be the cause. I think it's been fun to watch us really begin to hone in on the biology of this and become much more accurate or precise maybe in the drivers of what we've known for decades. And I just wonder, as you look forward into this field, and I know you did this a little bit at the end of your talk, what does this look like for a patient 20 or 30 years from now? Will we still be using neurohormonal antagonists, or will we have gotten so smart about this disease that we will target, gene expression and be able to mitigate the changes of heart failure?
And you laid it out beautifully on this whole journey of heart failure in the eras, right? And it's fascinated me that the working hypothesis of the biology will drive your therapeutic innovations. We stuck to digoxin and diuretics because there was a dropsy concept. And then the neurohormonal mechanism started laying one after the other. And now we're doing the hemodynamic aspect of unloading. And if we don't invest in the discovery of the biology, what I always notice is a residual risk. Right? If we're celebrating the mortality benefit, but we can't ignore that despite 4-pillar GDMT, it's not 100% survival. And that's where the residual biology discovery is what I think. And I think I put forth this concept of immunofibrotic hypothesis, and that to me would be the next phase of the biology that we'll invest in. And I would imagine an era where I see a patient in the clinic, do a genetic test, be able to tell them which pathway is playing the most, and then target the treatments and maybe get an injection once in 6 months, and which will be equal to all the GDMT and go away. And I didn't present the data today, but we also showed in our lab that all the GDMT medications have an anti-EMT properties. And that brings up the light that we were all focused on the cardiomyocytes, but they also have another impact, which is anti-fibrotic directly, despite the milieu of it. So the next decade is going to be exciting, and hopefully we'll be a part of that advancements.
Listen, again, I'm so appreciative of you taking the time to join us here at Texas Heart for the day, and it was wonderful to see you and great to see the work that you're doing. I'm excited to see how the story evolves about this target gene that you've identified that seems to be very important in the pathogenesis of heart failure. And we'll look forward to having you back sometime soon so that you can give us an update on the progress that you've made. So Arvind, thank you very much for joining us.
Thank you for having me. I'll look forward to that too.